I want to thank the organizing committee for the opportunity to be here with you. It's actually always a little bit scary for a surgeon to be in a group of very prestigious and very knowledgeable um, internists and multiple disciplines. But on the other hand, I think that makes it that much more interesting and potentially worth it. So without further ado, I will, what I would like to discuss today is how things are changing in the environment of hepatocellular carcinoma with the advent of metabolic syndrome. What this means in terms of surgery, in terms of transplantation, and what this means in terms of our overall management of this problem. I have nothing to disclose. So the whole idea is that there is a changing landscape where since we put together what metabolic syndrome is, what NAFLD and NASH are, they have actually replaced hepatitis, viral infections, as well as alcohol as the predominant causes of cirrhosis and hepatocellular carcinoma on a global scale. So this is fact number one. This has changed what our main enemy is and what will be in the next several decades. So that means that we have to change the treatment focus, and we have to address metabolic syndrome and its various elements so that we can intervene in a more timely manner in the development of both cirrhosis and HCC. So the goal is not to talk just about treatment, but also to talk about prevention, since we are learning and we know more about this new enemy. So I'm briefly going to discuss the importance of HCC, NAFLD and NASH, metabolic syndrome, and then mainly where does surgery fit in all of this. Is hepatocellular carcinoma a big problem? Of course it is, on a global scale. It's the fifth most frequent worldwide, with more than 500,000 new cases every year and significant number of new cancer cases. It's the third most frequent cause of death from cancer. And the key is that the more we know about, the more we learn about it, you really need a multi-specialty approach. You need the gastroenterologist, you need the hepatologist, you need the internist, you need the surgeon, you need the basic research element, you need a lot of different specialties. And the reason is that there are many different types of treatments. There's a wide spectrum ranging from resection all the way to transplantation, all sorts of different types of transplant, as you can see here. And in between these, you have local regional therapies, which are evolving as well as technology is evolving. But even more important is that because the etiology is changing, because our knowledge of molecular biology is changing, we're now talking about essentially microRNAs, we're talking about vaccines, we're talking about the PD-1 counseling, we're talking about immunotherapy. This is Human Fong, who is a surgeon. However, primarily he's a researcher, and he's a chair at City of Hope, which is a major oncology cancer center in the US. And what they've developed is a novel T-cell platform in order to go after HCC using the immune cells and activating them. That's number one. The other thing that we've all lived through and continue to do so is the new antivirals for HCV, for hepatitis C, which was a significant problem up to now. We had come to the point where we didn't want to transplant patients with hepatitis C. Why? Because you would get an immediate recurrence, and some of them would get back to cirrhosis very quickly. And all of this has changed with the new medications, where now it's a treatable disease. The risk factors, you all know them about for HCC, but what is changing is the bottom here. What is changing is non-alcoholic steatohepatitis and its findings. So what is this NAFLD NASH? I'm not going to go too much into details Professor Sinakos had very nicely discussed the key elements, so I'm just going to go very quickly as well as in the interest of time. So you do have a spectrum starting with the steatosis, which is part of it, more than 5%. However, the key is inflammation and excluding secondary diseases. And inflammation is what makes a difference with the obesity and takes us to NASH and fibrosis leading to cirrhosis. However, in this diagram, the other thing to keep in mind is that you can get hepatocellular carcinoma two ways. One, with the fibrosis, then cirrhosis, and then following that pathway, or you can get directly from NASH. So you do have a significant number of patients with NASH moving directly to HCC. There can be other etiologies of hepatic steatosis you can see here. We have to exclude them. As far as the global prevalence, we see that we have the highest numbers where in the areas where obesity is increasingly becoming a problem, such as South America, such as the Middle East, and the least presence, least prevalence is in Africa, where obesity is not as much of a problem. And if you look at how HCC has been up to now, it's exactly a different pattern, the opposite, where you have high numbers in Africa, Southeast Asia. Why? Because of hepatitis. So now all of this is going to change eventually in the next decade. Why? Because now we have the increased prevalence of metabolic syndrome, of NASH here and in areas in the Middle East. So this will change the areas affected. It is a spectrum, as we heard, and there are many different factors that can affect it. Again, I'm going through this quickly in the interest of time because we heard a very nice presentation. But all sorts of things can affect this spectrum of the evolution. And again, the key to remember, you can get to hepatocellular carcinoma through cirrhosis, but you can also get directly through NASH. And let's not forget that it's a disease that's starting from childhood, that can start from childhood. So when we talk about the evolution to NASH, essentially it's a revolution, because what has happened is that now NAFLD, cirrhosis, and NASH have become the second cause of liver transplantation in the US. And that means that it's responsible for between 5 to 20% of hepatocellular carcinoma cases in the Western world. So these numbers are increasing. And we have a high number of global prevalence of NAFLD. Now, the relationship does not mean that if you have NAFLD and NASH, you're definitely going to get HCC. The incidence is actually low. However, what makes a difference is that because NAFLD is affecting over 1 billion adults, you actually have that as a basic cause for liver transplantation and leading to a significant number of HCC and deaths. So it's actually the increased prevalence of NAFLD globally. Metabolic syndrome, it has its definition that we heard, very specific, 3 out of 5 of the above features. But what's key is the question, and I'm not sure that there is an answer, and my colleagues from hepatology are probably much better positioned to answer that, whether NASH NAFLD is a hepatic part of metabolic syndrome. There are certainly common elements, and there's certainly a back and forth relationship between the two. But obesity is not enough by itself. We have interesting findings from the National Surgical Quality Improvement Program, the American College of Surgeons, where there has been actually no relation between obesity and mortality in surgical patients. And not even that, but it's actually, we've had the obesity paradox, significant number of research where it shows a protective effect. So obesity is an intermediary, but what seems to play a significant role is inflammation in obesity. Now, we've heard about the basic management, which nutrition, lifestyle changes, medication, managing the complications, and yes, surgery being part of it, but as was very correctly pointed out by several of the previous speakers, you need a very careful selection of the patients with the BMI and symptoms involved. So you do have all these different types, and these are key. These are very important because if you can actually prevent things evolving to the metabolic syndrome, to NASH, to cirrhosis, or to HCC, then you can make a bigger difference than actually just treating it. But if all these fail, then what's left? That's where surgery potentially has to come in. Now, it's going to be a big part of surgery. It's going to be a big part of transplant. Approximately 25 million Americans will develop NASH, estimated by 2025, out of which 20% may end up needing a liver transplant. So these are very high numbers. But what is even more important and even more scary is the fact that out of these undergoing a liver transplant, within 6 months, 50 to 60% will have NASH recurrence. Why? Because of the immunosuppression and the role of metabolic syndrome. So this could be the new hepatitis C, where not only it's very frequent, not only it's number one, but it also comes back and you have to deal with it again, unless you aim at the root of the problem. And it's interesting that there was a very nice study from the Journal of the American College of Surgeons looking at patients with hepatocellular carcinoma and also had non-alcoholic fatty liver disease. And they saw that in these patients, they had increased postoperative complications, high risk of hepatic failure. These make sense to be expected, but they had improved 5-year survival. Now, this does not mean that it's actually protective. What it probably means is that there was a bias in this and patients were more carefully chosen. Now, bariatric surgery can have a role. And the challenge for us is to define what exactly that role is, and especially when that role is. There are different types of procedures for bariatric procedures. Just going to mention them, not going to elaborate too much. The general categories are these that lead to gastric restriction, so smaller stomach, smaller area, the lap-adjusted gastric band, something done quickly, easily, least effective. All these things are kind of like betting, gambling, in the sense that the more you risk, the more you may gain or lose. The Mason procedure, which is not performed anymore, the vertical banded gastrectomies, which again is making a smaller stomach, and all of these have some results, but they do have complications. Then there are the malabsorption procedures, where it's not so much making a smaller stomach, but affecting the absorption. Now, you have significant weight loss, but you do have significant complications because of the malabsorption. And the last is the Roux-en-Y gastric bypass and the sleeve, or basically you have a combination of decreased area, decreased volume in the stomach with limited intestinal bypass. However, the big question is what order do you do things? Do you do the bariatric surgery in a cirrhotic patient and then do a liver transplant? Or do you do them together? That sounds very dangerous. Or do you do first a liver transplant and then do the bariatric surgery? There is a limited body of research, but there is some. What we know is that the two types of bariatric procedure that seem to be the best combination of weight loss and relatively few complications is the Roux-en-Y and the sleeve gastrectomy. And the idea is that you limit the capacity somewhat, and you also affect the absorption somewhat. Now, regarding the sequence, the one that seems to have the good results are the sleeve prior to the liver transplant or the synchronous liver transplant with the bariatric procedure. And in terms of a more sustained weight loss and fewer metabolic complications. The one that definitely seems to have the biggest problem is doing the bariatric procedure after the liver transplant. And the reason potentially is immunosuppression and how that affects the healing in these already challenging patients. So putting things together, NFLD and NASH are a significant reason leading to cirrhosis, are a significant etiology leading to HCC, and more importantly, whether alone or part of metabolic syndrome, they're here to stay. And in the next decade, they will be the #1 etiology for liver transplant. The fact that NASH recurs in 60% after liver transplant means that the transplant by itself is not enough to solve the problem. You have to aim at the root of the problem. And how you do that? I'm not advocating surgery. I'm advocating actually what we heard in the previous presentations about lifestyle changes, medication, prevention. If you can deal with that, then you can avoid not only the problems with NASH recurring, but actually you might even be able to avoid the evolution of metabolic syndrome, cirrhosis, and HCC. Again, I would like to thank the organizing committee for the invitation and the opportunity to be here with you, and especially Professor Kotsis, and thank him for putting together again this excellent convention, very difficult times with all these multiple disciplines. Thank you very much.